I'm terribly sorry that my Chinese is definitely not good enough to give a talk, certainly with medical terminology in Chinese, which I'm very embarrassed to say. But look, I'm very honoured to be here, to be back in my homeland, to be in front of fellow colleagues, senior colleagues, to be able to talk about, I guess, a disease state that I'm very, very interested in and have some experience of dealing with, and like to, I guess, share perhaps my experiences, in Australia, and also to learn from for you as well, because I'm sure all members in the audience have definitely seen cases before. And given the rarity of the disease, I think any insight into it for any patient, I think, is very, very valuable. So just some disclosures. I had a few free lunches from a few of these companies, so my apologies. Now, the overview of what my talk's going to be about today is obviously a bit of a background on what is PNH, some epidemiological factors. Then we're going to talk about, well, whom should we suspect this really quite rare disease? It's got quite a lot of symptoms that patients can have that can be quite insidious, and ones that you really could be very hard to detect sometimes. And of course, probably leading to, well, how should we now test for PNH? I guess in the modern hematology lab, what can we do to try to pick up patients with this rare disease? So, a bit of introduction. So I think we all know PNH is exceedingly rare, right? And we know that what it is if I learn how to use this quite properly, that look, it is an acquired hematopoietic stem cell disorder, okay? And really what it leads to is this characteristic triad of intravascular hemolysis, really profound thrombophilia, as well as really, in some cases, progressive perhaps bone marrow failure as well. Now, of course, the rarity of the disease and the fact that the manifestations can be quite insidious means also there's significant delays in diagnosis if the patient actually ever is diagnosed. And you can see the incidence there that we know is close to about 1.3 per million patients, which we still think is probably underestimation of this rare disease. Now, we know that it really affects both sexes equally, which to some might be a bit counterintuitive, given that we know that the mutation on the PNH gene is actually located in the X chromosome, but I guess we've got to remember it's an acquired somatic mutation, not a germline mutation. Thereby, it will affect both genders, I guess, equally. So we know that this diagnosis historically has been bad, that if you look at the median age of diagnosis, patients in the early 30s, and we know about 17% of patients would be so functionally impaired that they would not be able to work, study, or do anything, I guess, really functional for most of their lives. And if you look at the outcomes of patients, that we know within 5 years of diagnosis, more than a third of patients will die, despite, I guess, historically the best supportive care, which I guess historically has been transfusion dependent, along with some perhaps steroids or androgens. Now we know that as a natural history, as the disease progresses, there's increased hemolysis and eventually leading to significant end organ damage and complications. And you can see that on this graph, I guess, just highlighting, I guess, the significant difference between patients with PNH and our normal aged and gender matched controls. So what is happening in PNH? Well, we know that the problem is that this mutation that's acquired in the PNH gene really leads to this population of stem cells in the bone marrow where they're unable to express these sort of quite critical terminal complement inhibitors, and namely, I guess, these two main ones, CD55 and CD59. Now, the reason why they're able to express these surface proteins is, unfortunately, this mutation really leads to the absence of a particular anchor that really that sticks the surface protein within the cell wall. And I guess that's what opens up the patient's cells, particularly the red cells, to be exclusively sensitive to, I guess, complement-mediated hemolysis, really causing the quite profound intravascular hemolysis of this disease, which leads to really the whole constellation of symptomatology. And we know that really the end product of this disease is that we're seeing in patients lots of thromboses, we're seeing end organ damage, and really as a result of all that, significantly increased mortality. And this just, I guess, this diagram really tries to highlight something quite well, I guess, how important these sort of GPI proteins are. So we know that without GPI, it's unable to, I guess, anchor critical components of the cell surface protein. So, for example, CD55 or decacellating factor. Now we know what this does. It prevents the formation and also destabilizes, C3, which is really a critical component of the alternative complement pathway. Now we know that CD59, what it does is that it protects, I guess, the red cells from really formation of the MAC complex, which what ultimately is what punches a hole, so to speak, in the cells and causes the homolysis. So really, deficiency of these proteins cause issues in the proximal alternative complement pathway, as well as the distal as well, opening it to attack. Now, we know that with this disease that the mutation is not the whole story, right? We know that the first step in terms of patient evolving to PNH is they develop this somatic mutation, and what you end up with that you've got a very small population within the bone marrow with that particular deficiency. And then we know something happens where there's some form of immune attack against the normal stem cells that do express GPI proteins. And with that immune attack, it basically kills off and selects out then this clone of really the abnormal cells, which take over as the predominant cell-producing stem cells. And we're still yet to understand why is it that those cells have a growth advantage in the bone marrow. And there's some theories on whether there's another additional, I guess, genetic mutations, or is it further immunological mediated mechanisms that's still quite unclear. But really what it ends up is, we then have this expanded population of really atypical cells that are lacking, I guess, GPI anchors, producing quite defective cells really throughout these three main images within the bone marrow. Now, to understand, I guess, how destruction of red cells is, we do obviously got to just briefly review the complement system. And really, we know with complement is a part of our innate immune system, and there's really three main, I guess, pathways. And we know that with the alternative pathway is the one that's where it has a very rapid immune response. And the reason for that is it's constantly being switched on. So we know the alternative pathway, C3, is constantly being deposited on really any cell surface. And what it relies on is actually something to switch it off. So I often, I guess, tell some of my medical students that imagine that C3 is like that guard dog that really doesn't, it's just constantly trying to attack something. It needs a leash to then pull it back once it latches onto something. So if you have any issues, actually we'll then go on to this diagram to show what I mean by that. So we know that what's quite critical in the alternative pathway is this amplification of this C3 as it attaches to, I guess, a cell surface. And in the absence of something inactivating it, which I guess we know CD55, its main role is to destabilize that C3 convertase activity, you then proceed down the terminal, I guess, complement pathway to the terminal phase where it was able to form a MAC complex. And this is where CD59 is extremely important, because that really prevents and protects the cell against this membrane attack complex, which is what causes the destruction of cells. And we know that this is bad, that if you have uncontrolled complement activation, what's going to lead to is really profound hemolysis. And this profound hemolysis is what releases, I guess, a free hemoglobin into the blood. So you get this hemoglobinemia. Now, we know that with this free hemoglobin, it's able to then deplete nitrous oxide really within our system. And that really is a cornerstone of a lot of the smooth muscle dystonia that we see in patients, because of the fact that with nitrous oxide depletion, there is now, I guess, inappropriate activation, contraction of smooth muscle constantly throughout the whole body, basically. Now, not only would that be an issue, we know that the intravascular hemolysis, as well as also, I guess, the problem where the megakaryocytes and the platelets might have be subjected to complement attack, that can cause activation and aggregation of platelets, thereby in all really creating really thromboses that could be spontaneous out of the blue. And we know that really PNH is probably one of the most thrombophilic states known to man. So if you see on this diagram, really quite highlights in terms of relative risk of thromboses, it's about order of 62 in sort of odds ratio, in comparison to what we think is a high risk thrombophilia and thrombin 3 deficiency. You can see it's far, far more thrombophilic than what we consider to be the high risk thrombophilic states. And really what's quite impressive about this thrombophilia is that we know that even PNH patients who are on anticoagulants, about 50% are still having thrombotic events, breakthroughs. And it appears that obviously the anticoagulation, really doesn't quite inhibit that complement-mediated procoagulant state within the body. And what's quite, clearly now seen in a lot of the registry studies that after you've had a thrombotic event in PNH, anticoagulation is just not enough, and they need something else. And interestingly, we know that even patients with minimal anemia, the ones that doesn't appear to require a lot of transfusions, they're still at significant risk of thrombosis. And you can see in this graph that the thrombosis rate in patients overall is about 7 per 100 patient years. Patients who are treated with anticoagulants, well, it's selective bias, they're the ones who already had clots, obviously. Patients who don't require any transfusions still have a significant rate of thrombosis as well. So what does that tell us? Well, that probably tells us that really what this means is that patients with PNH are at risk of thrombosis no matter how big a red cell or granulocyte clone there is. Okay? And you can see that on the x-axis here, the PNH granulocyte clone size, and we know that's a far more accurate way of seeing the actual clone size in a patient. Even patients less than 20%, we're still seeing 16% rates of thrombosis in these patients. And obviously patients with really significant, or we'll consider classic PNH, more than about 20% of patients are experiencing thrombotic events. So I guess onto, well, how then do we pick out the patients to test and whom we might suspect PNH? Really, I think we've gained a lot of information from the international registry, which I know obviously Taiwan and also Australia, of course, are contributing as well. And I guess in the most recent, actually I lied, at least the most recent analysis, we could see that in PNH patients, really 93% of patients are symptomatic. But I think the trick is to actually tease out those symptoms. And you can see there from really in order of the highest incidence to the lowest what these symptoms are. Now, fatigue, unfortunately, that's probably not very specific. I think I woke up this morning quite fatigued before coffee, so it's really not a great, a specific symptom as such. But you can see that, dyspnea really, was found in a lot of patients, about 64%. And you can see there's a whole constellation of seemingly unrelated symptoms: abdominal pain, erectile dysfunction, chest pain, and of course thrombosis, as well as renal insufficiency. But really, I think understanding the pathophysiology now, we now know, due to nitrous oxide depletion and smooth muscle contraction, that's what's causing these, really quite a seemingly unrelated bunch of symptoms: dyspnea, abdominal pain from any gastrointestinal involvement. We know erectile dysfunction is most definitely due to nitrous oxide depletion, as well as chest pain, which we now know generally is due to esophageal spasm in those patients. And renal insufficiency we know really from chronic renal hemosiderosis causing issues in some patients. So, and I think I've just covered, I guess, why we know now why there's such a strange constellation of symptoms, really all due to smooth muscle dystonia. Now, thrombosis, I know I seem to repetitively highlighting this, but I guess the reason why is we know in PNS patients by far is the leading cause of death. So we know that probably up to 44 and maybe in some series up to 60% of patients are really are dying from thrombotic episodes. Now we know, looking at registry data, about 30 to 40% of patients will have some form of thrombotic event really in the lifetime of the disease, whether or not they're on anticoagulants or not. Now we know that in terms of the pattern for venous thrombosis, it seems to occur in unusual sites. So hepatic veins, particularly Budd-Chiari syndrome, patients who present with this, really have a high chance of, harboring PNH clones. We know that cerebral venous clots and of course IVC, portal and splenic venous clots, also an unusual size of thromboses, where you can think of perhaps these patients have an unusual thrombophilia. And really, what's something that's quite rare is actual dermal vein thrombosis. And I've certainly seen this in a patient where they just got these strange discoloration in their skin, which was quite subtle, and actually was seen by two dermatologists who just diagnosed it as lichen planus. But in retrospect, had they biopsied the patient, they would have seen, I guess, dermal thrombosis. And of course we know arterial thrombosis can also occur, and really we think that's probably contributing to a lot of the sudden deaths that we see in patients. And I certainly had experience with a patient dying from acute MI, literally as he was waiting for treatment for anti-complement therapy. Now, this is how, I guess, scary thrombosis is in patients. We know that if you have PNH in your first presentations of thrombosis, the chance of you dying is about really 40%, well, sorry, the chance of survival, sorry, is only 40% within 4 years. To give you some idea how bad that is if you compare, I guess, this is Australian, Aussie data in terms of patients with cancer, in terms of the rates of death, it's pretty bad. So PNH has a higher rate of mortality than really most of the cancers combined, except only beaten by pancreatic or mesothelioma. So it really is quite a deadly presentation when patients do present with thrombosis. And just briefly on, I guess, chronic kidney disease, we actually know that about 64% of patients will have some degree of renal impairment, and really up to about 1 in 5 patients will have significant renal impairment where they may actually be considering, I guess, renal replacement therapies. Now, just a little bit on the dyspnea. Now, as I said, this is probably the second most common really finding in patients, and some of them can be quite subtle, because keeping in mind most of our patients are diagnosed quite young. And really, you've really got to tease it out. And I remember having a patient where I have to ask them, do you have any issues with walking upstairs? And they were saying, oh no, I'm fine, I have no issues with exercise tolerance. And then she kind of realised, oh actually, since I was probably in my 20s, I can't walk up a flight of stairs without stopping and feeling really short of breath, which is like, that's significant dyspnea. So it really can be quite prominent if you, I guess, ask the right questions. And we now know that the underlying cause is perhaps pulmonary hypertension, because really we know that once again the nitrous oxide depletion is sometimes disrupting, I guess, the really smooth muscle, the two muscles in the pulmonary arterial system. And if we look hard enough, in one series, 36 of PNH patients does indeed harbour echo-proven pulmonary hypertension. And it's interesting that once you reduce, I guess, hemolysis in these patients, there's an improvement of dyspnea, which really happens quite quickly. And of course, we've got to keep in mind that with the thrombophilic state, patients can indeed develop really subclinical pulmonary emboli, really as a cause or might contribute to the development of pulmonary hypertension as well. And this is highlighted, I guess, in this particular, I guess, publication by, of course, Anita Hill, who's got a lot of experience with, I guess, thrombotic issues in PNH. Really, she basically looked at, really, I guess, quite in-depth analysis of MRI, scanning of patients with MRI, which obviously is not something we do routinely. And it was pretty impressive that 60% of patients really show some evidence of multiple perfusion defects. And really, these patients had no reported, I guess, symptom or clinical evidence in their lifetime of having had pulmonary emboli. Yet they most certainly have issues with perfusion defects, really highlighting it can all be quite subclinical over time. Now, we know that there's really two main, I guess, intermittent groups that have put out some recommendations on who are the patients that we should consider consider screening for PNH. That's the ICCS and, of course, international, what's called a PIG group. Now, I mean, I won't go into too much detail, but really the ICCS guidelines is something that, I guess, in my clinical practice, something I certainly have incorporated in my sort of screening for patients. And really, I guess the key thing is that with anyone that you're seeing with intravascular hemolysis, if there's some associated unusual symptoms, is when you should be looking for PNH. So if there's iron deficiency or there's symptoms that may be consistent with smooth muscle dystonia, those are the patients that you really got to think about, that they may indeed have this rare condition. And of course, the key is that anyone really with an acquired Coombs negative type of hemolytic picture, you really got to start thinking, could this potentially be PNH? Now, another sort of alarm bell is if you're seeing patients with thrombosis unusual features, and of course, certainly in the Asian population, we know Asians don't really clot, right? It's really a Westerner thing almost. Whenever you see clots in patients, and certainly if I see Asian patients with clots, I always think about that's really quite unusual. Are they harbouring, I guess, this rare thrombophilic state? And the other thing, I guess, condition to look out for is, of course, patients with evidence of bone marrow failure. We all know that there's this association with aplastic anemia and also, I guess, really low-risk myelodysplastic syndromes, particularly the hypercellular subtypes. And those are the patients where, I guess, we know in some series, up to 40% of aplastic patients will have some degree of a PNH clone. Whereas, in some series, up to maybe 10% of patients with really refractory anemia as an MDS diagnosis may harbour a small clone as well. So we might just actually skip that slide. And in that as well. And go straight to, I guess, well, how do we test for PNH? I guess in the modern day laboratory. I guess this is these are the guidelines from the International PNH group, and you can see there that really there's three, I guess, main criteria whereby you could diagnose or label a patient with PNH. Of course, really the most important by far is being able to detect, I guess, in the peripheral blood cells, so not bone marrow, in the peripheral blood, this evidence that these cells are deficient in these GPI-associated proteins, which I'll talk about obviously in a few other slides. And of course, there should be some evidence, I guess, of clinical red cell hemolysis in the peripheral blood. And really, in order for us to make sure there's no associated bone marrow failure syndrome, really all patients should really consider, if appropriate, a bone marrow biopsy as well. Now, once you have completed those really main diagnostic steps, we could probably then classify patients into three main categories. So really, perhaps the most straightforward one is the one of classical PNH, where we know in these patients the clone size is huge, so they're generally more than 50%, and really quite obvious. And of course, reflecting that is that there's really quite clear evidence of intravascular hemolysis in these patients, high LDH, absent haptoglobin, and anemia of some degree. Now, in these patients, when we do a bone marrow biopsy, usually we'll find a bit of erythroid hyperplasia and hypercellular bone marrow only. And generally, we see no cytogenetic abnormalities, of course, in the bone marrow karyotype. Now, we know that there's a form of PNH where it is associated with bone marrow failure syndrome. Now, the clone size in these patients is actually quite variable. So we know that generally they're less than probably 10%. However, 10% of patients may harbour a clone greater than 50%. Okay? And that can change in the course of that bone marrow failure syndrome disease over time. Hence, the recommendation is we still, I guess, keep an eye on these patients to see if there's actually, the development of worsening or increased hemolysis in the blood. And reflecting this variable PNH clone, the degree of hemolysis also can be quite variable as well. And of course, when you do a bone marrow biopsy, you will see what the underlying marrow condition is. And what's quite interesting, the myelodysplastic syndromes, I guess in a few publications, we know that generally they're of low risk disease. And what we mean is that they're generally not the refractory anemias with the excess blasts. They're generally not your sort of refractory cytopenias with multi-lineage dysplasias. They're generally just plain old refractory anemias, which is quite interesting. Now, the third group, and probably the one where we're probably not as worried about, is what we term, I guess, subclinical PNH. And these are the patients where the clone size is really less than 1%. In these patients, of course, reflecting that small clone size, there's really no clinical evidence of hemolysis. It may or may not be also associated with coexisting, aplastic anemia, whether new or relapsed, and of course with myelodysplasia as well. So, when we test for PNH, what we look for is not only we want to see what the amount of clone is, we want to see what the type of clone within the red cells. And really we could identify with our current flow techniques really three main populations of red cell clones. We know that type 1 is really patients where there's normal expression of CD59. Whereas type 3 clones are the patients with no expression whatsoever of CD59 on the surface. And whereas type 2 clones are patients where they've probably got partial expression only of CD59. And really you can see in the flow graphs, this is exactly what we look for, where we try to see whether they've got type 1, 2 or 3 clones. And really by far the most common combination, so to speak, is patients with a dual population of a normal type 1 red cells and generally a significant type 3 red cells as well, which are the ones that are susceptible to hemolysis. Now, the ICCS have come out with really the Bible in terms of laboratory diagnosis of PNH, and they've gone so far in so much detail that they've in this particular publication with Borowitz, they talked about how one in the pre-analytical stage should prepare and test, and also recommending specific actual antibodies from specific vendors, because through their experience they basically have perfected or found the most optimal reagents to use to try to tease out these clones. And for red cells, really the main antibodies that are used, and certainly what we would use, is really CD59 and also CD235 or glycophorin A. Now for the white cells, it gets a bit more complicated because there's a bit more, I think, variability in different laboratories. Probably by far, what's become almost the gold standard is the flare antibody, which I'll talk a little bit later. And the reason for that is far more specific for the actual GPI anchor. So it's not looking at the surface protein, which is what the GPI is anchoring, is directly looking at GPI anchor expression, which obviously will be far more sensitive and specific when you're seeing an absence of that GPI anchor in cells. Now, I guess each laboratory will have different, cocktails of antibodies that we use. In our laboratory, we generally use just 2414, for granulocytes and monocyte clones. I guess we use a 5-colored cocktail in our flow machines to look at the leukocyte panel. And they're so detailed, they're actually given recommendations depending on what instrument you have. So whether you're a Beckman Coulter or a BD, they recommended specific antibodies to use. So a little bit about flare, how this is, I guess, really contributed and improved our diagnostic ability in PNH. Now what it stands for is basically fluorescent aerolysin. And what it is really quite a bacterial-derived protein, aerolysin. And look, it's pretty impressive that we know that it binds directly to the GPI anchor. Therefore, really by far, it's more specific and very sensitive for picking up leukocyte clones that are lacking GPI. So now, I guess why would we also look in granulocytes as well as red blood cells? Well, we know actually that granulocytes provide a far more accurate estimation of the actual PNH clone. And why is that? Well, we know, the red cells are being lysed, right? So they're being hemolyzed constantly in the patient's blood. And also, blood transfusions are going to affect the results as well, because what you've done with a transfusion, you just provide a whole bunch of type 1 cells to the patient, because donor-derived red cells would, of course, express CD59. And really, the gold standard now is that really all PNH reports should provide quantitative results expressing the clone size in both red cells as well as the granulocytes. And this is just, showing what the pitfall is. If we have just looked at the red cells only, we'll find that the type 3 population is only 31%. But in this exact patient, if you look at the leukocyte clone, it's actually 89%, right? Which is really giving us the true, I guess, underlying clone size. Now, just to make things even more complicated is the fact that, to our surprise, the clone size in patients does not correlate with symptom severity in our patients. Where you can see here really, this is data once again from in abstract form from the PNH registry. And you can see the 3 different populations they're looking at, where the granulocyte clone is what we'll consider small, less than 10%, an intermediate size, and also, I guess, significant clone size, which would where most classic PNH patients would sit. And if you look across the board in terms of the symptoms, there really isn't much separation, perhaps except for hemoglobinuria, that's actually related to clone size, right? So it really makes it quite important as clinicians for us to really question the patient when we see them upon review. What symptoms are they having? Now, what do we do, I guess, when we pick up patients with PNH clones? Well, I guess in stable patients or patients with less than 1% clones, these are the ones where you probably get away with just annual monitoring to see what the clone is doing. Now, perhaps more frequent monitoring would indicate for patients where have a clone size larger than 1%, because we know in these patients it can evolve, and have increased numbers of clones. So particularly, I guess, in patients with aplastic anemia are ones where I would look at probably every 6 months. Of course, it was recheck whenever a patient perhaps is describing perhaps increasing symptoms that are suggestive against smooth muscle dystonia. And of course, patients who are on early stages treatment, you monitor the clone size a little bit more frequently.